Hi and welcome. I'm Steve Martirano, and this is the Behavioral Corner. You're invited to hang with us as we discuss the ways we live today, the choices we make, the things we do, and how they affect our health and well-being. So you're on the corner, the Behavioral Corner. Please hang around a while.
Hello, everybody, and welcome again to the Behavioral Corner. Here I am again, hanging, Steve Martirano. What we do at the corner, you know, is we are real lucky. People come and go, and they walk by, and they go to the bodega, and they get their sandwiches, and they buy a newspaper, and and some of them stop by, and they have great stories to share with us, and fantastic expertise in areas we hope you're finding interesting. Okay, Behavioral Corner, of course, is underwritten by our great partners, Retreat Behavioral Health. They provide the funding for this, and in occasions, not unlike today, they provide the expert people we can call upon, and we're very, very grateful for that. Tom Longenecker joins us for the first time in almost a year. Tom's been a great help both on this program and just being able to pick up the phone and call him when I have questions. He is clinical supervisor for Retreat Behavioral Health, and he has a vast experience in both mental health treatment and addiction treatment. He also has an extensive background in theology, which is very interesting. I think those two things might not seem to coincide, but they do.
I would say they do.
The next time you try to pray your way out of a problem, that's what you're doing. Anyway, Tom joins us for an opportunity to take a look at something that, listen, we all know about our moods. We're here to find out on the Behavioral Corner today, what kind of mood you're in. Now, for many of us, all of us, we're all creatures of our moods. For most of us, managing our moods is fairly simple, sometimes automatic, but for many others, our moods become problems, serious problems sometimes, problems that can ruin a life or at best, I guess, make for a horrible existence. So we're going to take a look at mood disorders in general, and then take a moment to maybe get a little deeper on the issue of bipolar disorder, which I think most people are probably most familiar with, and is probably, most commonly thought of. So it's what mood are you in today and how to manage them with Tom Longenecker on the corner. Tom, thanks so much. I'd like to begin at your suggestion, because it's a great place. When we talk about mood disorders, what exactly are we talking about?
I think, Steve, one of the ways to start with that is actually in the term mood disorder. The mood itself is disordered, and it brings disorder to my life. Just as when we talk about personality disorders, which is a whole other topic, certain characteristics of personality are disordering to my life and oftentimes other people's lives as well. But so I think we start off with simply that the mood itself brings disarray to my life. It works against stability and often against stamina as well. So for instance, depression is perhaps the most common if we're going to talk about what is affecting mood. Anxiety. These are two things that, they tend to, both of them, with anxiety, there's a lot of difficulty with focusing. It's difficult to track a thought. My thoughts are running all over the place. We talk about it racing thoughts, difficulty sleeping, irritability. There might be some kind of suicidal tendencies and fear. With depression, we have often a difficulty in focusing. My thoughts are all over the place. They are racing thoughts. We have difficulty sleeping. It's often elusive, or it's the only thing I can do. There's often a degree of irritability that goes along with it as well. So I just respond to anything. I just kind of carry around a mood, spirit of always just easily finding it difficult to find joy or respond to things respond to my environment with some kind of gratitude, because everything just irritates me. And it's a very real thing. As well as with depression, there's a lot of tendency towards some suicidality and despair. So when we talk about those two things, you recognize that they sound a lot alike, but they're very different. Mm-hmm. And in the brain, they probably are functioning at different ends of a specific kind of element of the brain. But one of the ways to kind of distinguish between those is anxiety is often associated with agitation and high arousal. And depression is often associated with rumination and low arousal. So with anxiety, I tend to be amped. Okay, I tend to have energy I can't quite know what to do with, and you can kind of see that in terms of, kind of like fidgeting and other kind of physical expressions. With depression, I tend to ruminate on thoughts. I dwell on them as opposed to them racing around with me. And movement itself, my body is depressed. It feels through my whole body. In fact, that's kind of why we talk about feelings. Okay, I feel these things in my body.
Right. So it's interesting, yeah. To think of something, it's interesting to think of something intangible. A feeling is not matter, right?
Right.
But it is something that manifests itself very physically. So we begin right at the obvious point where you say, when we talk about mood disorders, it's not the mood that's by itself the problem, because we all have these moods, but it's that they become disordered. You mentioned anxiety, for instance. To a certain extent, anxiety is like the result of evolution, isn't it? I mean, there were, in order to survive, we had to recognize, for instance, the threat to our environment or the condition in our environment. And when it wasn't good, feel bad about it or feel anxious about it. I mean, the example is, if the lion is chasing you and you don't feel an anxiety about that, you're going to get eaten by the lion. So when we talk about anxiety as a disorder now, and that aspect is gone, right? Are we talking about a free-floating kind of a problem? In other words, I'm anxious, but I really don't have any reason to be anxious. Is that part of the characteristic?
Sure. And recognize anxiety by itself is just part of life. Like you said, evolutionarily, yeah, if I see a lion, I should be anxious. This morning I was coming in and suddenly the traffic was congested, and I pulled up my Waze and I saw it's going to take me an additional 20 some minutes to get here. Suddenly my chest starts to tighten up a little bit. Things are not going as planned. Okay. If you sit down to take a test or you step into the batter's box, you probably will feel a lot of the same things that people talk about when they say feel anxious. Okay. Some of this is simply a matter of what's going on inside. It's like there's a release of adrenaline into your body. This allows us to move quickly. This allows us to function. This has in the past allowed us to survive. The difficulty with anxiety when we talk about this as something that's more pervasive is that, again, it's disordering our life. It makes it difficult for me to remain in relationships. It makes it difficult for me to make decisions. It makes it difficult for me to move ahead. And so much of the issue is learning how to navigate with anxiety. And some of that is a matter of also recognize our world as a whole is perhaps not as anxiety driven. There's not just as many natural things to drive that anxiety that allow us to survive. At this point, some of those things are actually detrimental to our lives because it's not actually a big threat. One of the issues is oftentimes trauma. The experience of trauma at some point in life has basically activated that system of releasing adrenaline into the body, but it does not put the brakes on it. And so we start to see see so many things as red flags, see so many things as potential terror or potential danger when they're not. So part of the issue of anxiety is that it has changed our perception. So we're seeing and experiencing the world as more fearful, more dangerous than it is, which means we tend to respond to many things as potentially dangerous.
Yeah. There are things that you should worry about, and then there are things that you should not worry about. And I guess obviously the same conditions prevail with regard to depression. We have been, by the way, these disorders that we're talking about and these moods in general have been with us forever. They have never been more acutely affected, I believe, in our lifetimes than during this pandemic. I mean, there are nothing but reasons to be anxious. There are nothing but reasons to be depressed about what's been going on. Again, the dividing line is when you fall into a debilitating or counterproductive activity, and stopping you from enjoying your life and making things worse. Because it's okay to be depressed. I mean, we still can't go to the movies for the most part. So,
well, for instance, we first started talking about things that we probably would label anxiety probably in the middle of the 19th century. As part of the Industrial Revolution, we were developing trains. People were concerned that people could not travel that fast. But what also was happening was the pace of life was quickening. So that was new. And so we're experiencing a different kind of world. And that's exactly what's happened in the last year and a half with COVID. We're suddenly experiencing a very different kind of world. And so it's difficult to distinguish what is potentially dangerous, what is not. But it's also thrown off just our natural pacing. So that's part of again, you can recognize that's part of a reaction to the world around us. And some of that is distinguishing between how do I continue to thrive? How do I continue to move through this and navigate through this? And to what point does this now become debilitating to me?
Well, you're mentioning the Industrial Revolution as sort of the beginning of taking a look at these problems, because they were exacerbated because of the changes of the Industrial Revolution. Certainly, social media and the internet has accelerated everything. There's an explosion of information that has been, I guess, impacted very significantly in these mood disorders. Do you agree?
Well, and certainly, if you're really hooked into a lot of media, a lot of what the media runs is the same disaster or catastrophe or incident over and over. So that's basically a way that we're ruminating without ourselves being particularly motivated to ruminate. But we go through the same kind of scene over and over again. If you're kind of like in the news loop for the 24-hour news loop, and you can think back to any kind of catastrophe, it gets played over and over and over. And that's one way to deal with trauma, is to readdress it. But usually in that form, it's really just heightening rumination. I just see it again. I see it again. I see it again, which just keeps my whole self inflated and anxious.
Can you give us just a few of the maybe not so obvious symptoms of this? Because you run into problems of, well, are they just a gloomy person, or are they depressed? This affects everything. Tell us some of the ways it affects us.
Yeah, now the gloomy person might actually be struggling with some kind of anxiety or some kind of mood or personality disorder as well. But again, some people are just gloomy. Okay, but again, depression. There's a dysthymia, which is, I guess, for lack of a better word, a milder form of depression, but it tends to be longer. It tends to, I believe, the depression. I believe the diagnosis usually looks at it to last maybe 2 years or more. And this tends to be related
as a constant kind of state of affairs for someone.
It's probably always in some way present. It might be lighter at times, but generally this is the mood. If you kind of look at mood as a climate and emotions as the weather of the day, okay, this would be the mood. This would be the climate for a long period of time. I eat food, but it just doesn't taste like what I remembered it tasting like. I don't really get enjoyment from it. I really enjoyed fishing, but now I'm just standing in water with a pole in my hand. And so a lot of that is related to a detachment from life, and particularly the enjoyment and connection of life. I connect to others, but it's just difficult. It takes energy to be connected. And again, some of this is, in the aftermath of death, in the aftermath of a dissolution of a marriage, in the aftermath of fill in the blank. That would be a very normal response. Okay, this has been a body blow to me and my spirit. And so at some level, it is a very normal response. It doesn't mean that it's not debilitating, but it's an understandable response.
But when it's your default position, then you've got a problem.
Well, and because it is limiting to life. It is limiting to my personhood at that point. Certainly. Now
the meteorological metaphor you just used about the weather is interesting, because, and I know we want to talk a little more specifically about bipolar, but in reading up on bipolar, I saw it described once as a storm in
Mm-hmm.
your
Mm-hmm.
emotions. Is that an accurate characterization of someone who's suffering from bipolar disorder?
I think that's a good metaphor because it talks about the kind of the explosive and the extremes of what can occur across the dynamics of bipolarity. Certainly, yeah.
Before, well, let's take a moment here and talk about bipolar. Again, we'll do what we did at the beginning when we say bipolar disorder. What are we talking
Well, okay. So historically, this was referred to as manic depressive. Okay, and the term is like there's periods of mania, and there's periods of depression. We've since moved that over to talk about bipolar, speaking about polarity, those kind of different dimensions. And there's some kind of vagary, some kind of distinctions around making the different kinds of diagnosis there. There's bipolar 1, and then there's bipolar 2. We can often think about bipolar 2 as a milder form of bipolar 1, but they're probably actually quite distinct. But what are the things we see, particularly in bipolar 1, is a very elevated mood. Okay, going back to the mood itself, very expansive. The sense of self in a manic period can be very elevated, very grandiose. This is different from narcissism. This has to do with I think I'm going to create the cure for cancer. I haven't gone to medical school, but I don't have what do you do well? I do everything well, and it can become really detached from reality, extremely detached from reality. The other piece of that is sleep becomes very limited and decreased. So people can get a lot of things done. Just a few hours of sleep. Speech tends to be pressured, unending. If this interview, if you and I were talking, this interview could go for a long time because it'd be very difficult for you to cut me off. Kind of the pacing of life is very erratic. There's often high risk behaviors that can be related to sex, that can be related to spending, shopping. That can again go back to speech. I say things that are inappropriate that in another mood of my life would be unthinkable for me to say.
Mm-hmm, mm-hmm. Judgment is impaired. Judgment is impaired.
Certainly, judgment is impaired. Again, it really kind of seems to orbit around the sense of myself. That my sense of self is very elevated. I'm messianic, grandiose.
Yes. During this manic stage,
mm-hmm.
the person experiencing it doesn't feel it as anything abnormal or dangerous. They in fact enjoy it, don't they?
Often, and that's part of the perception is it's very enjoyable, and so people often resist the meds that will level that out because,
or even the suggestion there's anything wrong.
Cannot
right?
see that certainly because and it's difficult sometimes to point it out because I'm actually doing very well. In your field, you might be outselling everybody else, or you might be creating all kinds of art or what have you. You could kind of fill in the blank. It does tend to move at some point where that's no longer really functional, where it's no longer really serving you or yourself or your life anymore, because it's so disconnected from skill, from capacity, from reality.
There is obviously another side of bipolar, and that is the inevitable depression that follows this heightened mania, right?
And what is it? Is it the second law of thermodynamics? I forget which one. Which for whatever
goes
whatever
up, comes down.
Okay,
yeah, right.
to an equal measure. And so that is another side of the cycle. Now, people can cycle rapidly. We do have rapid cycling bipolarity, which can be moving through a day, between mania and depression. But it's probably more common to see periods of mania that are extended and periods of depression that follow that are also extended, as opposed to
in the depressive state that follows the heightened mania, or the mania rather. There's different dangers, are there not? I mean, yes, everything you've described about the heightened stage sounds pretty lousy, but there are other dangers in the depressive area, correct?
Certainly, and because at that point there is often still a degree of energy, and the sense of self is still disconnected. And so despair, people in a depressed state are at high risk for suicide.
Yeah.
Because again,
Yeah.
my sense of self, my relationship to kind of hope, is really disconnected.
Yeah.
I think for people who don't experience bipolarity, kind of some sense of vertigo is kind of an existential vertigo is probably a way to maybe understand a little bit of that, because it's exhausting to go through these moods. It's exhausting. It's exhausting at some point after that heightened period. It's exhausting to be in depression.
Are people who have bipolar disorder able in the depressed stage to reflect upon how their behavior in the manic stage was so problematic, or are they just regretful that it's over?
I suspect that ranges from person to person, but I believe that, yeah, I would suspect that I've seen that a good number of people in that stage are able to have some understanding of what was going on in the period. Again, it's certainly understandable. I would prefer to be in a heightened stage as opposed to a depressed stage. But yeah, there's some degree of that. But still, the issue is in depression, and this would be depression across the board, is there is a disconnection from self. And so my vision for myself, my vision for my future is really skewed and often limited.
All right. Well, so what do we know? What causes mood disorders in general, and bipolarity in particular? What's going on? It's not like they caught a disease, or actually, they have a disease.
Well, they have a disease, but they didn't catch a cold. They didn't catch a cold.
Right.
Right. Yeah.
It's not airborne. Huh? Right. So, do we know what some of the causes of mood disorders are?
There's we have hypotheses, and again, without being too elaborate, the question always is environment and nature and nurture. And yes, the answer is always yes. The answer is yes to both. Okay. There might be some family tendencies that we can trace across generations. However, if you're raised in a pretty erratic environment, that's probably going to breed more tendencies to respond erratically as well. So that's difficult to really kind of say, well, to really point to genealogy and say, well, there it is. That's, we see it here, we see it here, we see it here. So there's most likely some kind of genetic predisposition in some ways. However, again, we tend to come back to some kind of trauma or something that was very disassociating, that's something that was very erratic in one's life, which has developed this kind of off-kilter way of being. Something has thrown me off kilter at some point in life. Whether that might be just the environment that I grew up in as a child, whether it's a specific several incidences. So when we're talking about bipolarity, particularly, there tends to be some kind of events or just environment that my erratic behavior developed in.
Mm-hmm. What role does stress play as a trigger?
Well, again, stress, like anxiety, is it's a piece of life. When people with people who struggle with bipolarity, stressors often can kind of set the stage for an episode. So one of the ways of working through that is trying to develop stability. And that's stability with meds, that's stability with therapy, that's stability just also with routine, diet, everything that's, and what that also can do is people get, sometimes people don't care for stability. They don't care. It's the same. The routine gets old, and I want something different. Yeah.
So, we're talking to Tom Longenecker. He is clinical supervisor with Retreat Behavioral Health, and he's taking us through the ABCs of mood disorders. And we're going to take a moment and pick it up with how do you treat this? How do you treat mood disorders? Behavioral Corner, don't go away.
Retreat Behavioral Health has proudly been serving the community for over 10 years. Here at Retreat, we believe in the power of connection and quality care. we offer comprehensive, holistic, and compassionate treatment from industry-leading experts. Call 855-802-6600 or visit us at www.retreatbehavioralhealth.com to begin your journey today.
Tom Longenecker is our guest. Always call upon Tom when we've got questions that we don't know anything about. And certainly mood disorders is so broadly a problem in our culture, in our lives, that we wanted to take a look at some of them and their causes and symptoms. Now I want to take a look, Tom, at how you treat this. Let me begin with, I get paid to ask the dumb guy question. So here's the dumb guy question. Okay, if our behavior and our moods are a function of the way our brains work, and I think that's true, and there's something going on in our brain that's making us either depressed, anxious, or bipolar, what techniques or methods are there to treat the thing that can correct it, the problem, when that's what's not working properly? Does that make any sense to you?
Certainly, yeah.
All right, so what are some of the ways we treat mood disorders and bipolarity in particular?
Yeah, certainly. I just want to refer back to some of the distinctions between bipolar 1 and bipolar 2, is that bipolar 2, while seeming milder, tends to have increasing and longer periods of depression. So it is also very, very debilitating as well. But, so there's several ways of working with any of these mood disorders. Some of that is psychotropics, medication. Okay. Because as you pointed out, at some level, whether my neurons made me do it or not, at some level, this is what's going on in the neurology and the brain chemistry. Okay. And so there's a range of psychotropic meds that are utilized. This is one of the reasons, and I can't speak very specifically about this because I'm not a psychiatrist, but it's one of the reasons to get a very good diagnosis, because if you're being treated for depression, that's probably most likely not the way to treat somebody who has bipolar. And so so getting a really good diagnosis and a clean sense of clarity around what is going on, because they are not the same thing neurologically.
Yeah, well, let me stop you right there when we talk about meds. The class of drugs we're talking about, are the benzodiazepine drugs? Is that what they are?
Oftentimes benzodiazepines. Again, psychiatrists, this is not my field.
No, I understand that.
But psychiatrists will use often a combination of sometimes beta blockers, SSRIs, antidepressants, and benzodiazepines.
The reason psychiatrists do that and not psychologists is that is a medical decision that has to be made. But isn't it? And again, I know this isn't your field, and if you don't feel like it's your place to have an opinion about this, my sense is on some level, and maybe this is true about all diagnosis and then treatments, is that it's less science. It's certainly science, but there's some art to this. Correct?
I would say there's an awful lot of art to this. Yeah.
Because as I understand it, when you begin treating somebody with a mood disorder, the first drugs introduced may not be the right drugs.
And this is my plug for good psychiatrists, because a good psychiatrist is going to have some understanding of being able to track this across time, recognize how do the meds also interact with one another, and to recognize when something is working and when something is no longer working. And again, a psychiatrist will often kind of look at that sometimes in terms of, this is my initial goal, and then we're going to transition to some other things. So that's my plug for good psychiatry, is that they'll have an understanding of that, particularly how those meds are working and interacting with each other and the person.
It's also important for the sufferer of the mood disorder and his family to understand this and not grow frustrated or angry that they're not seeing results. In addition to the meds not being very effective, they also can have the negative impact on the patient by making it easy for them to say, well, it's not working, I'm not taking it anymore, I don't like the way it makes me feel.
Certainly.
Typically, I guess there's no typical way, but that process of finding the right medicine, does it take a long time or longer for some people, or how does that work?
Well, partly because meds don't necessarily do their work, in the first dose. That will take oftentimes weeks. sometimes months to be able to see the implications in terms of how that's interacting with somebody's own neurology. So certainly, if you're looking for a quick response, a quick fix, meds probably will not actually be able to provide what we're expecting or hoping for. That's oftentimes, at least several weeks, usually, to be able to see how that's affecting people. Again, that's going to range person to person and med to med. The benzodiazepines primarily are slowing down the central nervous system. That's primarily what they're doing. So we're not experiencing some of the symptoms, some of the physical symptoms, and some of the other issues that go along with that heightened mood.
So let me move now to the more standard stuff, the stuff that we're more familiar with through media and reading and stuff, and that's that's talk therapy, or the couch and the psychiatrist at the other end. What's the role there? Since, as we just got done explaining, these problems occur with regard to brain chemistry. I mean, how can you talk somebody into having better brain chemistry?
Well, we can talk people into working with their lives and using different skills and resources. And the other piece is, we do have this kind of very active dynamic between our brains and our behaviors and our attitudes and our thoughts and our emotions. So it can feed both ways. It's not simply, we're not simply, and this might be where my theology background comes in. I guess the challenge is, did our neurons make me do it, or is there a greater interaction between my thoughts, what I'm doing, and how that actually affects my neurological pathways, which we suspect it does. So there's a couple different kinds of methodologies that have been developed that we tend to utilize with people working with bipolarity. One is dialectical behavioral therapy, DBT. And it's basically the short description is basically in the name, that it's an evaluation of your behaviors, and looking at them and it's often very work intensive in terms of people keeping cards where they're monitoring their actions, their behaviors, how they're understanding the world. Cognitive behavioral therapy, again, is really looking at a lot of how I perceive things, how I'm thinking about things. And so it tries to raise that up as to evaluate it. Its granddaughter is ACT, acceptance commitment therapy, which tends to focus primarily on how do I live out of some of my deepest values. Now, by themselves, these might not necessarily derail, an episode, but they are ways to maintain stability through the times and to build strength and greater resources through the time outside of an episode.
Yeah. It also sounds like this would fit with your theology background. It keeps the person in a place where they're able to make a leap of faith, where they can say, if I keep thinking and talking about these things, maybe I can get to a better understanding of what's wrong.
Sure.
Rather than what's wrong.
Certainly. And it also it provides a discipline, a practice of slowing down and developing reflection and introspection.
Yeah, work on it. Final thing, and we're going to let you run because we know you're very busy. There has been a lot written lately and broadcast about a field that is, not even new. It's pre-new, but it has to do with treating some mood disorders with psychedelics, from LSD, which is created in a lab, to psilocybin, which is grown out of the ground. It's mushrooms. That field they're trying to open that field up, get some of these drugs reclassified so that you can study them. And just recently, 60 Minutes did a piece on work being done with post-traumatic stress disorder and MDMA, which is known by its club drug name as ecstasy. Do you see that field growing in the next couple of years?
Well, certainly. And I think it's important to remember that neither of these are new. Middle part of the 20th century, I particularly believe in some hospitals in the plains of Canada. LSD was being experimented with and used in experimental treatment of people with schizophrenia. It's been used in also terms of treating substance use and nicotine dependency as well. And that suddenly fell out of favor in the mid-1960s. People turned on, tuned in, dropped out.
Thank you, Dr. Leary.
So the response was very reactive in terms of any ability to fund and do that research. That recently, and I'm not quite sure in the timeline, it's in the last decade or maybe two, where there's been more research. And so the use of LSD is a potential, might be a potential kind of medical intervention in the future. One of the difficulties with it is the difficulty to control it. It's much more difficult to manage than many other kind of meds. MDMA, also known as the club drug ecstasy, that was used by therapists in the Bay Area, particularly around working with people with trauma, because it could create an environment of safety where they were able to go deeper and deeper. And then that again became used in the club scene and exploded across the country. So both of these are really returns to earlier research. In terms of what their potential is, it's difficult for me to really say because I'm not really aware of all of the new research on them. In terms of, like anything, it's unlikely to be it's unlikely to provide everything that people would hope it provides, but that doesn't mean that it doesn't have some potential likelihood of being something of a way to try to treat some of this.
The real danger, as I've seen and read, is that these drugs, while illegal, are available. You can get them. There are people who claim they can microdose you and help you with some of these things. People got to be very careful about doing this with the right people under the right circumstances, or it can just make everything much worse. But yeah, I think it's going to be interesting in the next 20 years or so. Tom Longenecker, thanks so much. I don't know whether there's an answer to this, but I'll give it a shot. If people are feeling some particular way and they know it's not right, who should they turn to? Family, professionals? What is somebody out there now depressed and they know they're depressed? Who do they turn to?
And I think the answer is everybody, but certainly because you always kind of say it takes a village. Not everybody's going to understand. So one of the key parts of this is to turn to somebody who can understand. So it might be your first step might be your PCP, your primary care physician. If you're working with somebody in therapy and you're saying, one of the issues is it's imperative to be honest. People often come to therapy and they're a little slow to really reveal everything that's going on with them. Clergy, rabbi, some people in families, some people you might have somebody in your family who you feel that you can reach out to who can be able to provide at least support in trying to find some ways to address this. But I would say everybody. But again, it is key, however, oftentimes in recognizing who is going to be understanding and supportive. It's oftentimes family will already recognize this, but not every family is inclined to understand the depths and the complexities of any of these mood disorders. Many times families are just frustrated. So it's important to be able to bring in your crew, bring in the people who can understand and be asking the questions like, where can I get help?
Yeah, and never forget that what we're looking at is a disease.
Certainly.
And not somebody misbehaving for the sake of misbehaving.
Certainly.
Tom Longenecker, thanks so much. It's always a pleasure to talk to you.
It's always a pleasure to be with you, Steve.
Incredibly busy, so I appreciate your time. Your time as well, you guys that are hanging with us. Don't forget to follow us on Facebook and like us where you like us. We'd love to hear from you. Plenty of opportunity to feedback. There are topics you want to hear on the corner. We want to hear from you. We'll catch you next time on the Behavioral Corner. Take care, everybody. Bye-bye.
That's it for now. And make us a habit, hanging out at the Behavioral Corner. And when we're not hanging, follow us on Facebook, Instagram, and Twitter on the Behavioral Corner.